So Stephanie?
Thank you. I'm delighted to have the opportunity to discuss these data with you. So although Diana isn't able to make it today, I think I'll do an okay job. It won't be as polished as Diana would do it, but these are data from my study, so I think we'll be okay. And I also want to point out that the data used in this study are the same, come from the same participants that were just presented, that Lori Scott just presented on. So there'll be a lot of overlap in the methods and the sample description, so it's the same sample. And I also want to highlight, to begin with, how this is distinctive from what Lori's presented on previously. And that is that in this study, what we're going to be examining is a different protocol. We're going to be examining data from our ecological momentary assessment protocol and how that maps on to the daily affective experiences of adolescent girls with borderline personality disorder features. So as we've heard a lot about today, affective instability and related constructs appear to be very central to borderline personality disorder. And for the purposes of our talk today, we're defining affective instability as intensity in emotional experiences, lability in emotion, so changes in emotion across time, as well as reactivity to stressors. Specifically, interpersonal stressors seem to be very important in eliciting emotional reactivity in these patients. And then having a sustained response, a slower return to baseline for these patients. And there's been limited empirical work assessing affective instability in adolescents. So since affective instability is composed of all of these different components, it's very difficult to have a self-report measure or a laboratory measure that can really tap all of these different aspects of affective instability. So it's difficult to use those types of assessments to measure this, and so we're going to be using ecological momentary assessment to be able to assess the different components of affective instability. So specifically, we can make indices from data that we collect on a day-to-day protocol about girls' mood regarding their intensity, lability, reactivity in daily life. So even though there hasn't been a lot of work examining affective instability in adolescents, it's actually a very critical time to do so. And the reason that this is because the neural circuitry that's linked with emotion regulation, this circuitry changes very rapidly during this developmental period. And so it makes sense then to try to understand how changes in people's experience of affect might be changing in conjunction with this change in neural circuitry. And it's also the developmental period that's heightened by risk, especially for mood disorders among adolescent girls in particular. So until adolescence, there's about equal prevalence of mood disorders in boys and girls. And then we know in adolescence, there's a huge increase, a huge difference that starts to emerge between boys and girls in their rates of depressive disorders specifically. So this is an important time to start to understand how do girls really experience mood or emotion on a day-to-day basis in their daily lives, and how this might help us understand the nosology of borderline personality disorder and how it might be distinct or different from the adult experience of affective instability. So I mentioned this briefly earlier, but there are challenges with traditional forms of measurement. There's memory biases associated with self-report questionnaires, and questionnaires also fail to tap into hot topics or these areas that really get kids going, which are usually something to do with their parents or peers. And so in the lab, it's really hard to have a stimulus that's as powerful as the one that they would experience in their daily life. So it's very important to think beyond these traditional assessments when we really want to understand the emotional topography of the day-to-day experience of these girls and how affective instability might play a part in that. So this study relied on measuring affective instability using ecological momentary assessment. And we used real-time data. It uses real-time data on emotion and behavior in daily life. And the result of doing this is it increases generalizability, and it's more ecologically valid. There have been a lot of studies assessing affective instability in adult samples. However, there hasn't been any really to use this method to assess affective instability in adolescent samples. So what do we know about affective instability in adults with borderline personality disorder? We know that from several studies that the negative emotions that they experience are more frequent, more intense, more variable. They have greater instability across periods of weeks. And there's also an increased persistent reactivity following stressful life events. And then for positive emotions, they occur less frequently in daily life for individuals with BPD. And we also know that there's also more variability in their positive emotional expressions in daily life. And so we wanted to see if we could replicate these findings regarding affective instability, or at least some of them, in an adolescent sample enriched with BPD features. And we wanted to see if it was the same or different than what we had previously observed in adults. And in doing so, it will help us understand more about the phenomenology of borderline personality disorder in adolescents, how it's similar or different, help us understand the heterotypic continuity and discontinuity across time. So affective instability also is important in the context of parenting, and as Lori presented on earlier, these adverse invalidating environments are theorized to be related to the development of borderline personality disorder symptoms. Specifically, abuse and neglect have been implicated, as well as specific parenting practices, harsh discipline, dismissive strategies around emotion, critical strategies about emotion. And we think that parenting is likely to interact with BPD symptoms to predict changes in the emotional dynamics of affective instability in daily life. So we're interested to examine in this study how supportive parenting practices buffer affective intensity in daily life. So Lori presented on how parents' supportive practices buffer against the development of borderline personality disorder symptoms across time. But what we're looking at is a more micro assessment of how these supportive practices actually influence girls on a day-to-day basis in their daily lives, how it influences their negative affectivity, reactivity in daily life. So here are some hypotheses. We expected BPD symptoms to predict more negative and less positive affect in daily life. We expected BPD symptoms to be related to more emotional lability in both negative and positive affect as measured in daily life. We expected BPD symptoms to be related to more intense negative emotions in response to negative events in daily life. And based on the adult literature, we didn't expect to see a relationship between borderline personality disorder symptoms and more intense positive emotions in response to positive events in daily life. So we didn't expect BPD symptoms to be related to feeling incredibly happy after something positive happened to them. But we did expect girls to experience more negative affectivity like anger in response to a negative event happening to them in their daily life. And then lastly, we explored whether parenting, and you'll see we looked at support and validation, the same code that Lori examined earlier, and how it moderated the relationship between these BPD symptoms, and we looked at intensity of rating, so just intensity of emotional responses for the purposes of this presentation. So the current study comes from the larger Pittsburgh Girls Study, as we previously heard. 2,500 girls and their caretakers assessed over 13 years. Girls were ascertained into the sample when they were between the ages of 5 and 8 years old. And for my study, I've selected a subgroup of them, a very small subgroup of 110 girls who I've enriched this sample for affective instability. And these findings that we're presenting are the data we have to date, which is on 88 of these participants. Oh, I'm sorry, no. The original cohort study was started in actually 2000, and the cohorts were between the ages of 5 and 8 when they were brought into the study. And when they were brought into my lab, they were age 16. So the 88 participants were 16-year-old girls and their biological mothers. And we have a subset of these coded, the interaction task data are coded for a subset of 74. And you can see that the majority of the girls were receiving public assistance indicating the extreme poverty in the sample. Most families are existing at below 200% below the national poverty limit for this country. Very impoverished sample. And the majority identify as African American. And this is a very unique sample because I feel very privileged to get to work with this data because it's very rare that these families would come to participate in a research study. It would be very difficult usually to have their parents provide consent for their girls to participate in a research study, but we have over 13 years of demonstrating our commitment to these families and our ability to lean in and help them connect with resources when needed. And we've worked very hard to maintain a relationship with them, and so I feel very privileged to get to use this sample for my study as well. Okay, so the procedures for this study include, the procedures we'll talk about that are relevant to this study are in the first visit, we do clinical interviews and a conflict discussion task, which you heard about earlier. And then in visit 2, we do a pupillometry task, which I'm not going to present on the findings from that today, but the reason that's important is because that's when we give the girls their cell phone, okay, for the EMA protocol. So we schedule that 1 week out, and then we give them the cell phone and we orient them to the ecological momentary assessment protocol. And then over the next week, we call the girls and do our protocol, which I'll go into detail next. And we do that for 1 week, and then they return the phones to us at the end of that week. So the BPD symptoms were assessed with SID-P, and it's just the sum of the 9 BPD symptom severity ratings. And we're using the maternal support and validation code that we independently rated from the conflict discussion task. I think it's also important to note that all of the coders were blind to any other information about these families or these participants. They actually had very little affiliation with the main study on purpose. So we brought these coders in and trained them independently of the larger study. And so at the pupillometry visit, girls received the cell phone-based semi-structured, the cell phone, and we gave them instructions about how we were going to use the cell phone. And they could only receive calls from the study on this cell phone. It was a very cheap cell phone that had very little market value. So I don't think we lost any cell phones in this study. What happens is that there's a semi-structured brief interview that's administered over the phone. So we actually call the participants. And this is different than a lot of the protocols that have been done with adult samples. And actually an adult sample that I'm doing right now, we devise like these fancy apps and then have the app beep them and do all this stuff. But for this adolescent population, I wanted to start to see how compliant they would be with an actual, the interviewer facilitating these calls. And so we called the girls 28 times over the course of 1 week. They received 4 calls per day, and each call lasted between 5 and 7 minutes. And the end of the day calls were slightly longer because we asked about some broader things that happened to them over the course of the day. So for example, we asked about what was the most negative thing that happened to you today, and how did you respond? And then the other calls throughout the day asked just about mood, how are you feeling right now? Who are you with right now, and what are you doing right now, for example? And so for the intensity variable, we're using ratings from a couple of PANAS items that we asked at every single phone call. And so for positive mood, we assessed for happiness and excitedness at the time of the call. And then for negative mood, we're assessing sad, ashamed, irritable, and hostile. And we're conceptualizing higher ratings as being indicating greater intensity of their current emotion. And then lability, we just use the standard deviation of the affect intensity. And there are many more preferable ways that we can measure lability, and we will do so. These are just preliminary data. It'll give you a sense of just the overall fluctuations that these girls experienced over the course of the week. And then in terms of reactivity, we conceptualize this as affect intensity ratings in response to the most negative and positive events at the end of each day. So we use multi-level models to account for the repeated affect ratings at each call. And so this was done to look at intensity as well as reactivity. And then because we had that standard deviation for the lability, we just used multiple regression because that's just one score over the course of the week. So we had a random intercept, which allowed girls to have their own kind of starting value on emotions. And then we had fixed effects of BPD symptoms, maternal support, and then the interaction of BPD symptoms and maternal support. And that's just for the intensity rating. So we'll go through each of these in turn. So for intensity, you'll see that that BPD symptoms were associated with lower intensity ratings of happiness, so lower positive affectivity ratings, and higher intensity ratings of all the negative affectivity variables we assessed, including sadness, shame, irritability, and hostility. So suggesting that these girls experience higher levels of negative affectivity, more intense negative affectivity in their daily life, as well as slightly, at least less happiness in their daily life. And this is consistent with what we have found in the adults with borderline personality disorder in terms of their intensity ratings of affective instability, of affect over the course of weeks. And then looking at lability, we see that girls report more positive affectivity lability over the course of the week, so more changes, as well as in negative affectivity, they report more labile irritability over the course of the week. And this is also consistent with the adult literature, showing that there's more variability in positive affectivity in daily life for adults with BPD, as well as more variability in irritability, or negative affectivity actually in general. And then if we're looking at reactivity, so this is how upset or how did they respond to the most negative event of the day. And here you can see BPD symptoms were related to a more reactive, angry response to the most negative event, as well as a more upset response to an angry event, suggesting that they were more reactive to negative events. And then in terms of positive emotions, they also actually were more reactive to positive events as well. So they reported experiencing more happiness, excitement, feeling more energetic, and joy in response to the most positive event of the day. And that's actually different than what we found with adults with borderline personality disorder. We see that they're actually not reactive in a positive way to positive events, which I'm sure fits a lot of your clinical experiences with this population, that it's sometimes difficult to generate positive affectivity in response to positive events. But in this sample, they reported doing so, which I think has important implications for this study in particular, and we can talk about that in a few minutes. So then looking at the next hypothesis regarding how parenting may buffer these BPD symptoms, having more intense negative and positive emotions, we see that there was a significant interaction between borderline personality disorder symptoms and maternal support, suggesting that the more maternal support children had, the less negative affect they experienced, which you can actually see from this graph. So girls with high BPD symptoms who had high levels of maternal support actually didn't experience really any more negative affect in their daily life compared to girls with lower BPD symptoms. But those girls who experienced low maternal support or validation and had high BPD symptoms, those were the girls that experienced much more intense negative affectivity in their daily lives. So we saw a similar pattern of findings regarding the daily, what is emotion like in the daily lives of those with borderline personality disorder features in adolescents to those findings that we've seen with adults. And we see both this dysregulation of negative and positive emotions over the course of a week. However, we did see some differences from adults with BPD in that adolescents with borderline personality disorder features at least appear to have some reactivity to positive events and they feel more positive. So I think this is important because it highlights some unique things about this sample. So first, this sample is a low-income sample, And a lot of these girls have very externalizing presentations. So a lot of these, we have actually pretty low levels of depression in this sample, higher levels of things like conduct disorder, oppositional defiant disorder, ADHD. And so it may very well be that it's the burden of depression in adults that blunts their affect in response to positive events. So it's interesting to me that maybe tracking the comorbidity of depression and borderline personality disorder might be very interesting to try to understand how depression influences patients with borderline personality disorder's ability to experience positive affect. And I also think it highlights the importance of parenting, especially during adolescence, and having an impact on girls and even in their daily lives. Even though the girls weren't necessarily with their parents, even just that snapshot of showing that they had more support and validation during this conflict task, that carried over into daily life, I think it's pretty powerful. I think it's a pretty interesting message and idea that maybe something that you could do could have, in a session, could have implications in their daily lives beyond that session. And I think it also speaks to potentially using EMA in treatment to use more individually tailored assessments to understand really what are the emotional problems that these girls are having. And it also will provide real-time feedback and monitoring to be able to chart progress and make it very tightly correlated to their daily lives and their daily experiences. So in terms of the future directions, where we're going with this is we have a lot of data. I don't know how many of you have worked with EMA protocols, but probably, we have thousands and thousands of variables for each participant. And so we are very excited to get to clean these data more and to learn more about which indices are going to be really exciting and useful. One of the things we're excited to look at are social partners and how social partners in their daily lives affect their mood, their affect in daily life. So we ask girls at every call, how are they feeling, who are they with, what are they doing? I think it'll be interesting to see how who they're with may buffer their expression of or their experience of emotion. And then we also are going to examine the behavioral consequences of affect, affect intensity, lability, reactivity in terms of alcohol use and binging. And so because of the way the data are structured, we will be able to see if intensity sort of precedes alcohol use and binge eating, for example. And then in the very near future, we're going to look at additional statistical methods to assess lability. So like I said, we just looked at the standard deviation for this study, but it really just is kind of a gross measure of lability across the week. So we can get at an overall level of how much the girls were changing, but not really the more subtle, complex changes that happen from morning to evening or from weekday to weekend. And so we can do things like that with more sophisticated lability indices like mean successive squared differences. And then there's also this notion of affective polarity to see, are girls experiencing a broad range? Are they reporting a broad range of emotions? Or is it really they're just relying on one sort of set of emotions and that's what they're experiencing, suggesting that there's little differentiation that they're reporting in their experience of emotion. So I'd like to thank NIMH for funding this study, and I'd like to thank you for your attention this afternoon. So thanks.
Several speakers were not able to come, and Marianne Goodman from Mount Sinai is our next speaker.
So first of all, I'd like to introduce myself. I'm Marianne Goodman. I'm, like Nancy, a clinician. I've been treating patients with borderline personality disorder for over 20 years. While Charlie Swenson did start out the morning session, I'm glad to be able to follow suit because he was my DBT trainer 11 years ago. He may not remember me at the training, but he may remember that I had my 2-month-old with me at the training. And I think my claim to fame is having the youngest participant at a DBT training. And I also think that this is the first case study of DBT skills in infancy. But I've also been very fortunate to be able to work with Larry Seaver and his group for the past 14 years, where I've had the opportunity to integrate neurobiology into my clinical work. And my goal this afternoon is to stimulate a discussion between the clinicians and the neurobiologists in the audience. And I'm going to do that by talking about preliminary data on DBT treatment response. Okay, so we have some big questions. We want to say, what can we learn about the mechanism of psychotherapy, in this case DBT, using brain imaging? And what can we learn about the underlying biology of the disorder using imaging and DBT treatment response? Another question clinically is, how can we predict who's going to do well in DBT and then likewise other psychotherapies? Many of you have seen this slide before if you've been to DBT trainings. And it's really the biosocial theory of borderline personality disorder, where there's an interaction between the biology and an invalidating environment, and this leads to pervasive emotional dysregulation. This is taken from Marsha Linehan, and it really dictates the course of emotional processing in BPD. And the yellow dotted line would be for sort of people without the disorder who are triggered by some kind of emotional activity. They have a response, and it comes back to baseline pretty quickly. But individuals with borderline personality disorder are triggered very easily. They have a steep response. They stay in a hyper-aroused place for very long with a slow return back down to baseline. I will say that yesterday afternoon when we were trying to figure out whether or not we were coming to the conference, I think I was in the hyper-aroused state with continual triggers every time we got an update, which seemed to be like every couple minutes. That's the world we live in now. I will say, though, in that hyper-aroused state, individuals with poor impulsivity will do all kinds of things to be able to modulate that emotional state, and they might resort to self-injury, suicide, property destruction, substance abuse, or violence. And the feeling is that this kind of emotional responding can be kind of distilled down to two different components. One is a vulnerability, which might involve the amygdala and insula, hyperactivity in those two regions. And the second is difficulties with modulation in prefrontal regulatory regions. Okay, I'm going to shift gears and talk a little bit about DBT. This audience is quite educated, but it is one of the psychotherapies in the APA guidelines. It's the treatment where there is the most empirical data supporting its use, and it really talks about targeting emotional regulation skills, and this is going to become important later on in the talk. I do also want to point out that there are people who don't respond to DBT, about 50 to 75%, and I think we'd like to be able to identify who those individuals are because this is a very expensive, labor-intensive treatment. I don't think this slide is up to date because Charlie mentioned there were 17 randomized clinical trials, but it's really just to kind of highlight the fact that DBT has quite an empirical base. Okay, I want to shift gears now to talk about neuroimaging and psychotherapy. There is one case study that's in the literature on 2 people who got psychoanalytic treatment, but there is only one trial that actually uses DBT. And this is a study by Schnell and Herpertz, where they looked at 6 individuals who had borderline personality disorder and were offered 12-week inpatient treatment. And they compared that with 6 healthy controls. And what I found very interesting about this study is they were scanned with a passive viewing paradigm, so they just looked at pictures, 5 times during the course of the treatment. Day 1, day 7, and the actual DBT program itself started at day 8, day 35, day 63, and day 91. As somebody that does DBT research on an outpatient basis, it's very hard to keep these people longitudinally. I think this is brilliant to do it in an inpatient way where you have a captive audience. So what did they find? They did find that in the DBT individuals, they did find decreasing response in particular brain regions, the anterior cingulate, the posterior cingulate, and the insula. And these are the regions that you might expect because it had to do with involving less cognitive control over the ability to regulate one's emotions. They distinguished responders from non-responders, and they used this was before the XAN-BPD had been developed, and they just used a response to a clinical problem. So it was sort of clinically based. And they determined that 4 out of the 6 individuals had this response, and those 4 individuals showed less activation in particular brain regions before and during the course of the treatment, and these activation places were the amygdala and both hippocampus. And that's what you can see in the brain region above. Okay, so I want to shift gears and talk a little bit about some of the work that Erin Hazlett's been doing in our institution. And this is going to be very important in terms of where I'm going to go with this talk. And it has to do with this definition of habituation failure. If you show a picture to the amygdala, it has a response. If you show the same picture, you repeat that same picture, the amygdala says, oh, I've seen this before, and it doesn't respond as greatly. However, this is not the case in borderline personality disorder. These individuals do not have the dampening of the amygdala on the repeat picture. This is the paradigm that Erin used, and I want to refer people to this 2013 Biological Psychiatry article. Is correct, Erin? Okay, because I think it's a fabulous, fabulous article, but it also forms the basis of what I'm going to be talking about with the DBT trial. And basically what she did was she had pleasant, unpleasant, and neutral pictures that she showed once and then repeated it during the course of the fMRI, and took measurements of amygdala activity during both novel and repeat. And what she found, and actually she did this in this is probably the largest group of BPD patients, and compared them to schizotypal personality disorder, so it's a comparison control group that's our patients, as well as healthy controls. And here you can see in the red, if I can get this to work. Oops, not to do it. Okay, you can see that there's sort of a heightened response that takes a very long time to come down to baseline. That starts to look like the diagram that I showed before. So here's some empirical evidence that suggests that borderline patients have prolonged emotional responding over time, and here's the actual picture itself. And you can see the normal controls in blue, and the schizotypal patients actually have a heightened response but come down pretty quickly. Now, in addition to the kind of the prolonged responding, Erin also showed the patients the novel picture and then the repeat picture. Okay, and here you can see that on the novel presentation, the borderline patients are here, but show them the same picture again, and look what happens. They have increased responding, and that was not the case with the healthy controls in the schizotypal patients. Now, if you then break it down to looking at unpleasant pictures, neutral pictures, and pleasant pictures, you can see this happens most with the unpleasant pictures. So there's this notion that patients with borderline personality disorder do not habituate to unpleasant pictures. Okay, so that's just to kind of summarize that. There's a significant difference in responding patterns of borderlines and controls, as well as schizotypal patients, to a second exposure of an emotional stimulus, and that in borderline patients they responded more, and that this failure of habituation seems to be specific to borderline personality disorder, and it actually may underlie the excessive emotional reactivity that we see in this disorder. So we wanted to ask the question, what happens to this habituation failure when you treat patients over a year in traditional DBT? Okay, so we actually thought, I will mention, I'll give you the punchline now, incorrectly, that the patients who had less habituation failure, basically they were doing better, we thought those individuals would do better in the treatment. And we also thought that the treatment actually would help with this particular problem with habituation. Okay, so this is the study design, and I want to mention it's not a trial where we compare it to another treatment. This was open label DBT. Everybody got DBT. And what we distinguish is the people who responded and the people who don't respond. So everybody got 12 months of DBT, and at baseline, they received this fMRI paradigm, the same paradigm that Erin's been using in her study. And we repeated at 12 months the fMRI again. We also did affective startle at baseline 6 months and 12 months, but I'm not going to present that data today. So this was an outpatient treatment. We started out with pretty nice numbers, 25 borderline patients. And by the time we finished the trial, we had 16 completers, 11 who had imaging data. I had one person who got braces the week before the trial was finished. I thought I was going to take the braces off myself from her mouth, but unfortunately, she told me, well, they'll come off in 2 years, so then that wasn't going to help me. We had several people also who became quite claustrophobic and refused to have the imaging done the second time. Okay, so the treatment trial itself was standard DBT, a weekly skills group, individual sessions, and telephone coaching, so the empirically based treatment. We did send tapes for adherence ratings, and we did track them clinically with serial assessments, and we chose to use the DERS scale, the difficulty of emotional regulation scale, as our outcome measure, and defined those that had a 25% improvement from pre-treatment as our treatment responders. Now, I want to kind of highlight that all of these patients were medication-free for 12 months because we wanted to be sure that the effects that we were seeing on the brain really were coming from the psychotherapy. I don't know if people here have done clinical trials, but to maintain borderline patients off meds for a year was I think is probably my second claim to fame. It was a heroic feat. Okay, so 18 to 50 years old, and they could not meet criteria for bipolar disorder, nor current depression or substance abuse. Our IRB was very, very careful because we were depriving patients of medications. That was a criterion to come into the study. They would not let us take patients who were suicidal, nor people who had any kind of current depression, because that you could treat with an antidepressant, and it would be felt like you were withholding treatment. All our healthy controls had no axis 1 or axis 2 disorders. And this sort of gives you a sense of who the patients are. Most of these patients were recruited from Larry Siever's Mood and Personality Disorder Research Group from Mount Sinai. They were a community sample, and you can see that very few of them had previous extensive therapy or treatment. Only one had a previous hospitalization. About 2/3 of them had been on medications in the past, not helpful, and about a little over 1/3 had previous psychotherapy. So this is a very different group than other studies where you're taking patients off inpatient services and such. Mostly female, as one would expect, and as I just want to show you that while they didn't have current depression, about 3/4 of them had a history of depression and actually high levels of current anxiety disorder. This is really just to give you a sense of sort of the baseline self-report measures, a ZAN BPD of about 18.1 and a HAM-D depression score of 13.8. Okay, so moving to the actual fMRI task itself, it's exactly the same paradigm that we showed before. Patients had it at baseline and at 12 months and went into a 3T Sigmund's Allegra MRI machine. And this is just to kind of remind people that what the task is. They're looking at pleasant, unpleasant, and neutral pictures at novel and then repeated. And this is over 30 minutes of scanning. We chose to look at a region of interest, including the amygdala, in part based on the findings of Erin's paper, and we wanted to hone in on this idea of habituation failure. I won't go into extensive detail about the imaging processing other than to say our colleagues in the radiology suite spent weeks doing pre-processing of the data and were able to give us bold activation levels of the amygdala, which we then followed up with a series of ANOVAs. So again, just to remind people, we had 11 people who got imaging before and after 12 months of DBT, and 8 of those individuals were responders and 3 were non-responders, and there was not any statistical difference in the age, gender between our healthy controls, which, by the way, had the same imaging done at 0 and 12 months. Okay, so I just want to pause here for a second. This is the slide that looks at bold activation levels in the amygdala at baseline and then at 12 months. And the interesting thing to see here is that our borderline patients are having much greater amygdala activation. And again, this is collapsed across novel, repeat, hemisphere, and picture type. So if you just kind of look globally, heightened amygdala activity, which comes down with treatment. And the paradigm is actually quite good. I mean, the reason why we chose to have healthy controls is because you want to show that 12 months later that the paradigm is successful. And it looks like the activation levels are pretty consistent at baseline. And healthies, remember, they had no treatment. Okay, if you then try to correlate that clinically, it turns out that the people whose amygdalas came down with treatment, this correlated with changes in the DERS score, and even more interestingly, with this particular subscale that looks at emotional strategies. Now, DBT actually teaches patients emotional regulation skills, so it's quite interesting that those patients that learned the strategies had lower DERS scores and had the lowest amygdala activation. Okay, now this is a very complicated, scary slide. But I sort of want to paint a story with it, so just bear with me. And this is a slide that starts to get at the habituation story, where we're going to be looking at the differences between right and left brain, picture type, so pleasant, neutral, unpleasant, and then again, this novel and repeat. And what I want to do is just focus on this large circle, which I'm going to now put in the next slide. And the story that I want to try to tell people sits right here, looking at the unpleasant valence. So then these are unpleasant pictures that are being shown not at novel and then at repeats. So this is the second time they've seen the picture. You can see that for our DBT non-responders, they start out lower. So their amygdalas are not activating so much at baseline to the second picture, and they get worse over 12 months. In contrast, our DBT responders have heightened amygdala activity at baseline. So you show them at baseline, the second unpleasant picture, their amygdalas are firing. But after treatment, it comes down. And that's impressive. It's sort of at the same direction as the healthy controls. Okay, sticking with this same story, what can we say about who does well in DBT? And if we can actually find out who those individuals are, that would be very helpful for clinicians. So this is now looking a little bit more at the 6-month data, where we have a slightly larger data pool. And the interesting thing here is these are all the individuals who had quite poor amygdala habituation at baseline. And these were our non-responders. This, again, is 6 months, so we have a larger pool to come from. But I think it starts to underline the fact that the patients who are having, strong negative reactions to repeated negative things happening to them are the patients that do well in this treatment. And if you can somehow teach them skills how to better regulate their emotions, it leads to patients feeling better. Okay, so let me try to take a step back and summarize everything I've talked about. Looks like 12 months of DBT treatment quiets the amygdala. It looks like habituation difficulties are lessened with DBT treatment. We think that the acquisition of emotional regulation skills is important in terms of helping patients with habituation. And interestingly, non-responders, and I think we, as a field, need to really figure out strategies for non-responders. They continue to have this habituation failure and have amygdala hyperactivity at 12 months. Looks like that baseline habituation difficulties in the amygdala, the larger those difficulties are, the better these patients do in DBT treatment. Okay, so how does this fit in with the rest of the literature? Actually, our baseline findings of amygdala hyperactivity don't actually correspond with what's in the literature. There was a recent meta-analysis that reports amygdala deactivation in borderline personality disorder. Now, we sort of tried to think about that, and it may have something to do with axis 1 comorbidities. It may have something to do with the fact that we have a different task. Our task is just kind of viewing. It could be that our methodology of just singling out one region. But I think we have, as a field, have to better understand the actual role of the amygdala in this disorder. Our findings are consistent with the other imaging study in borderline personality disorder, which of course is DBT. And it also is consistent with other psychotherapies that look at affective disorders, which do show that with successful treatment, the amygdala quiets down. So I think the direction of what actually the role of the amygdala is, and then how specific is this idea of amygdala habituation problems, specific for borderline personality disorder and for DBT treatment response. So limitations, this was a small N study, so even though we ended up with 11 subjects, each one was a year-long treatment. Our analysis was limited at this point only to the amygdala. We're not sure how generalizable our findings are to other samples where there might be axis 1 comorbidities of PTSD or even major depression because our sample is so clean. And our task really required the patient to just view the pictures. Other studies, and I wish Harold was here because his task asked patients to actually enhance or suppress or distance, which activates different regulatory regions depending upon what you ask patients to do. So what does this mean clinically? The clinician in me is hoping that if we can continue this kind of work, we might be able to say something about how patients get better. It tells us something about DBT, psychotherapy in general, but also what does it mean when you are a non-responder? And it might help us guide treatments, either shorter, more effective treatments, as Mary was saying earlier, or even treatments for those individuals that don't seem to be responding to these psychotherapies. So our future directions include a whole brain approach to examine other regions that are important. These would include the insula, the anterior cingulate, and we also want to look at correlational analyses between the amygdala and the prefrontal regions. We'd like to correlate our fMRI findings with other measures, and that would include affective startle, which we have an active projects with that. And in our next study, we'd like to have a larger N. We'd like to have additional predictors of DBT treatment response. But I think also we heard a lot today about the importance of teaching skills. Is it any skills or is it particular skills? And it would be nice to actually have some documentation that the patients are actually learning the skills. I mean, they sort of say they self-report measure, but to actually figure out which skills in particular they're utilizing. And we'd like to compare our DBT response to another comparison group so we can understand the specificity of the findings of DBT versus psychotherapy in general. This was work done as a Career Development Award. I want to thank the many people who helped me with this project, and they include the imaging analysis people, David Carpenter and Chuck Tang. I couldn't have done this without the help of Erin Hazlett, Larry Seaver and Antonia New, who are the mentors on this particular project, and the several DBT therapists who worked with these patients unmedicated for a year. Okay, thank you. Oh, that's not fair, Antonia.
Okay. I was going to say, I am your friend and a mentor on this project, but I have a question relating to your non-responders. So if you can you go back to the slide of non-responders by any chance?
I can try.
I mean, of your
This one or the-
no, back for, not the predictors, that
This
slide.
one, okay.
Yeah. So look at the middle panel. The non-responders are dramatically numbed. So they're dramatically down. And what does that mean? And I think first I should say this was a hugely ambitious project which you pulled off, and it's an incredible data set. So I don't mean to be giving you the hard question.
Right.
But the hard question is, other people have shown borderline patients really kind of at baseline have a kind of lowered amygdala response to emotional stimuli. if the amygdala goes offline, does that mean the patients just aren't even responding at all? I mean, what does this mean, that happens to positive and neutral, but not to negative? Any thoughts?
Well, I think one of the, I'm not sure I'm going to answer your question directly. I think it's a fabulous question. I think that's what we're grappling with. We do know that people who dissociate do not do well in this treatment.
Yeah.
And I don't know if that's part of the explanation. We did have a couple people who were severe dissociators, but they weren't having a lot of tremendous symptoms nor emotional regulation problems because they were so dissociated.
In fact, that is actually the question, which is whether, I mean, you have a small number of people, and in fMRI studies that I've done in PTSD, actually, the amygdala is very low in response, and they're highly dissociative. So there are too few people in the you do this treatment too well, so only three people didn't respond. Right. But those who didn't respond, I wonder if those are people with either a lot of trauma or dissociation. That's the question, and maybe that's what accounts for some of the variability in the literature.
Right. No, this is why we need a larger N, and I think we need to be much clearer about kind of measuring those sorts of tendencies, and I think actually developing treatments that target dissociation more effectively. I mean, you could argue that mindfulness supposedly does that, but if you're not successfully treating the dissociation, even if you're trying to be mindful, you're not learning the skills. Okay. Yes? Oh, the predictors. Yeah. Yep. Correct. Well, it looks like you have an equivalent group of non-habituators on the other side. So at the beginning, you could not have told this group from this group. So what this does tell you is that if you're low, the treatment's not going to help. Right. But if you're high, it really doesn't tell you whether the treatment's going to help or not. Is that correct? Am I interpreting that correctly? Yeah. I mean, I think this is one set of predictors. I think with a larger N, maybe we can differentiate it more successfully. But certainly the non-responders are the ones that, with low habituation, are not doing well in this treatment. It's a necessary but not sufficient condition. Yeah. Okay, thank you. I mean, would you agree, Erin? Yeah. Hi.
Hi. Thank you for this talk. I really enjoyed it. 3 questions. The first is I'm wondering if you have any data on history of maltreatment that might help you kind of disentangle some of these findings.
Data on?
History of maltreatment.
History of non-treatment.
Maltreatment.
Oh, maltreatment. Yes, we would have trauma questionnaires on these people. Okay. We can go back and look at that more specifically, but this is not a tremendously traumatized group. They're kind of community sample of people doing fairly well, starting to have symptoms, got meds, but not a lot of other psychotherapy. But it's certainly something we could spend more time looking at. I will say that the serious dissociators, yes, those individuals had more trauma levels.
Mm-hmm. And then my other question is whether you have any specific data on how often patients are utilizing the exposure piece of DBT in terms of being mindful to current emotion and actually engaging in what we would expect to create some habituation. And then related to that, I guess, is whether you think there's a role then for something like D-cycloserine to be added to treatment of DBT if this is something that is predicting response.
I think these are excellent questions, and we should talk with you because we've been, as our group, been talking about ways to maximize the treatment effect. Yeah. Okay. Oh, one more?
I'm sorry. You alluded to laterality, but it seems like the data that you presented at the end was right amygdala. Was it not true of the left amygdala?
It was true of the left amygdala also, but it was that picture was the nicest to kind of tell the story. We found it in the left amygdala also.
Okay. Because one of the things that I found in the literature is that a lot of these, what look like contradictory studies show actually one is left side, one is right side when you see activation or
That's interesting.
deactivation. So I wondered if, it sounds like you didn't find that it was more right side, but I was wondering if you had any theories about laterality in that respect.
I'm turfing that one to Aaron to answer.
And also, I know you're planning to do correlational studies. Do you have a sense of whether what we're looking at is primarily an amygdala mediated effect, or it's really more of a cortical mediated effect on the amygdala for DBT?
Yeah, I mean, the whole notion of the habituation failure is happening in the amygdala. I think we would say that it's primarily happening at the level of the amygdala, with prefrontal modulation problems probably secondary, but I don't know that that's kind of what no? We don't know.
Right.
Right. Yeah.
Great, thanks.
All right, thank you.
Our next speaker is Jill Hooley, Professor of Psychology, Harvard University.